for our partners from USA. I welcome you all in today's session and to this knowledge sharing forum of the Africa Cancer Research and Control ECHO program. My name is Annette Nakaganda, a cancer epidemiologist based at the Uganda Cancer Institute, and I happen to chair the steering committee that is leading this Africa ECHO, and I will be leading today's session. A special welcome for those attending this ECHO for their first time. Just to let you know that this ECHO aims at expanding and sustaining best practices for cancer control planning and implementation in Africa, as well as utilizing evidence in directing the cancer control efforts in the region. So today's session is particularly aimed at expanding whatever we discussed in April about the COVID pandemic when it had just come. And now it looks like we have to learn to stay with it and define a new normal. So today's session, we really want to realistically hear from one of the countries, the real challenges being faced and what should be considered and addressed as we make decisions reopening cancer care services amidst this pandemic. So I welcome you all once again to this important discussion. But before I invite our first speaker, I wish to remind you that we are going to have two short presentations as detailed on the agenda, one by Dr. Kunos from Ethiopia and another one by Dr. Warren Phipps from Uganda Cancer Institute, Uganda. I would also like to remind you to mute your microphone, please, if you are not speaking. And if your bandwidth permits, please turn on your video, as we would like so much to see your faces during our interaction. And please use a chat window at any time to introduce yourself, because we know some people were not here at the beginning. And also, I want to remind you that we are going to be recording this session and will be sent out to each of you who shared their email addresses with the African Cancer Research and Control Secretariat. So at this point, I would like to invite our first speaker, Dr. Kunos from Ethiopia. And allow me briefly introduce Dr. Kunos. Kunos Abdallah is a public health professional with over 20 years of experience in health system policy research, program development, and strategic planning. His career is built on cumulative experience from grassroots health program implementation at district level to national and international health program designing, strategic leadership, and management. Currently, Kunos is a senior advisor to the Ministry of Health Federal Ministry of Health Government of Ethiopia on non-communicable diseases and cancer. Dr. Kunos holds a Doctor of Medicine from Addis Ababa University and Masters of Science degree from Heidelberg University in Germany, with majors in community health and health management in developing countries. So we are excited to hear Kunos sharing his experience of the pandemic and cancer care services in Ethiopia, so that it forms a very good basis for our discussions on how to address these challenges and open up the cancer services amidst this pandemic. Dr. Kunos, you are very welcome, and over to you, please.
Thank you very much, Annette, and also good morning there, and also good afternoon in Africa and most parts of Africa. And I'm very happy to share our experience from Ethiopia during these last few months dealing with the pandemic on the ground. And I will try to focus on the situation, what the situation looked like in Ethiopia, and also pick on some of the challenges we are facing as we try to deliver cancer care services in the country. So the next slide, please. Next, please. Yeah, so I just want to start with a bit of background and overview so that we understand what the real situation look like for a cancer program in Ethiopia. So the previous slide, please. Yeah. So Ethiopia is a big country and the second, I think the second or the third populous country in Africa, next following Nigeria, and usually Egypt and Ethiopia like have more or less the same population. So that's why I was confusing the third or the second. Anyway, it doesn't matter. So with regard to COVID, the first case in Ethiopia was reported in March, mid-March 2020. And since then, the cases have been increasing steadily, and the figure we have at August 4, it was actually around over 19,000, with mortality from COVID at 1.7%. And today I have the figure that it's over 20,000 already. So the case is actually picking up very quickly. According to the Global Can data, we have annual cancer incidence of around 7,000 new patients every year. And the striking thing about it is taking into consideration all cancer centers in the country, we are only treating about 15% of all cancer cases. So the coverage, the treatment coverage is actually pretty low. One of the factors is related to the human resource availability and the facility availability in the country. And our oncologist to cancer patient ratio is quite appalling, and it's 1 to over 5,000 patients, cancer patients have to be taken care of by at least one oncologist. So it's quite pretty sad in terms of the match between patient and the care providers. Our chemotherapy initiation waiting time has been reduced significantly. It used to be like 3 to 6 months in most part of the past 5 years. But recently, because of a number of initiatives at national level, our chemotherapy initiation has gone down to 1 month to start treatment. But our radiotherapy waiting time is still very, very lengthy. It's around 12 months, which is 1 year. And unfortunately, most of the patients die while waiting for radiotherapy to start. Actually, most of the radiotherapies we are giving is palliative, even though the waiting time is such a long time. So during this long waiting time, we have seen a lot of upstaging of cancer stages, and usually moves faster. So it's very, very sad situation. Next, please. Next slide.
Okay, it seems I'm trying to move it for my. Oh my, so sorry. Let me try sharing
Okay.
one more time.
So while she's trying to go to the next slide, I want to add a few points on this slide. Actually the sad news is, like, when we call patients for the radiotherapy schedule, in most instances, the patients are reported to have passed away, like 40% of cases, which is again very, 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 very sad. So what is the actual problem on the ground? The problem is, experience from recent epidemics in the world, it shows that usually when this kind of, this scale of pandemic happens, usually the existing service gets significantly compromised, because the attention usually diverts away from the routine care to the pandemic. So it is very usual incidents. And we have seen this experience also in West Africa during the Ebola. And also most countries are also having this kind of experience, even with the current pandemic. So the real problem is this one. But the good thing is Ethiopia has recognized this concern as early as possible during the pandemic. And we developed what we call the essential services provision or implementation during the pandemic. So in the next slide, you will see that there is a guidelines that Ethiopia has put in place very early this year to make sure that all essential services continue, including cancer care, regardless of the level of the pandemic. So while we do the preparation on the pandemic, we manage that the services would continue as usual, particularly so with the cancer care, as there are a lot of implications if the treatment cycles are interrupted. Well, next, Christine.
Yeah, it's me now projecting, but when we reach at a stage of going to the next slide, it can't move on. Sorry. Oh, sorry.
Yeah.
Yeah, there you are. Thanks.
Very good. So if that is a problem, then what are the mitigation measures? I mean, you know, the thing is, if we, the good thing is to understand the problem on the ground. Once we understood the problem, then we have to come up with an alternative measures to address those challenges. So what Ethiopia did is, the first thing the ministry did is to set up a high-level technical team to oversee the continuation of non-COVID essential services. So from all disciplines, all areas of health service, they have been in this committee or in this national task force to make sure that this service continues. To assist the lower level, healthcare providers at all levels, the implementation guideline was quickly put together based on WHO recommendations. The implementation guideline for non-COVID essential health services in Ethiopia during the pandemic. So this was developed, published, and then shared across all levels of healthcare so that health professionals don't panic and then understand what to do in this situation. So this guideline was very much useful in terms of guiding the frontline providers to understand the situation and at the same time continue the routine services. And in the guideline, the NCD services, including cancer care, was particularly addressed because there are a lot of issues related to non-communicabilities. First of all, they are at a high risk of having high impact from the pandemic, from the COVID-19 infections, and also at the same time, the continuity, the long-term treatment provided to cancer care and also other non-communicable diseases would easily be affected if services are interrupted because of the refilling of medicine, because of cyclical treatment. And we cannot afford to interrupt any treatment at this stage. And if we do so, actually, the implication is much more disastrous than the pandemic itself. So these were the things that we have made sure that all health workers understand and take into consideration. Not only the health workers, all hospital managers, the leadership in the hospital administrations, all of them, they have understood this. Not only that one, in the guideline, it also gives provision on orienting or providing awareness to the patients themselves, because some patients assumed that all services have been interrupted, so they tend not to come. And also on the top of the panic, that the panic of the fear of contracting the virus while coming for the service, these all issues were the concern of the general public. So information was given that this is normal and they have to continue their treatment. If they don't do that, the other side of the story is also not very good. So this kind of trade-off was done with users. I mean, in the users of the service. Next, please.
Oh, I'm trying.
Yeah.
Sorry, I don't know why it hangs. Yeah, thanks. There you are, Kunuz.
Oh, yeah, next. I think we can skip this slide. This is just the structure of the at the ministry level in terms of the high level and the cascading structure of COVID management. So I just want to put this for people to refer to. So please pass on this one.
There you are.
We can skip this one. Okay, so in the guideline, what were the provisions? I think this is also important for other countries to see as an experience. Cancer treatment is one of the essential services that should not be interrupted, and therefore the existing few cancer treatment facilities should continue service without interruption. So this is what is clearly put in the guideline. The second, attention should be given to the continued provision of cancer care for children particularly and adults as well without interruption to prevent progression of disease. And also the facilities that provide cervical cancer screening, which is supposed to be well, relatively non-emergency in terms of care, but we have also managed to continue cervical cancer screening in all facilities. One of the reasons why we did this is we didn't want to, like alter the momentum in terms of screening, because we have done quite a lot in terms of improving national screening program in Ethiopia for cervical cancer. So if we interrupt at this stage, then probably it's very difficult to go back to the service and restart again. So it's better, even if the uptake might be a little bit slower, we pushed that the screening program at least continues in place. But we have seen we have made a follow-up supervision of all facilities, but we have seen that the number of women coming for screening have gone down a little bit. But it's good that the services are still in place. So that part of cancer care has also continued. Actually, we have done the same for other programs like screening for hypertension, diabetes, and other programs also continued because we wanted to keep that practice in place. Next, please. All right, so what is the actual practice on the ground? Okay, we got the implementation guideline, we got all training, we gave all training, orientation and all that. So what's actually happening on the ground as a result of these interventions? First of all, the routine cancer services have continued uninterrupted, and we have monitored this one very closely, and in all our facilities, cancer care has not been interrupted in any way, so it has continued, which is a good news. And we also made sure that supply of medicine, including PPEs, are secured through the government procurement system, because there were a lot of challenges with the PPEs. It is actually the case with the cancer program previously, but on top of that, when this pandemic comes, people were demanding, providers were really asking for more protective personal protection equipment. So we actually managed to provide that one and made sure that all facilities have adequate supply of PPEs. And also the cancer treatment commodities are not interrupted. We particularly monitored this one because of the flight restrictions and the cargoes are not coming into the country. So the first service that would be affected is this kind of commodity movement. Logistic for cancer care would be affected. So the government also particularly addressed this one and made sure that the logistic, the goods movement will not be interrupted because of the international flight restrictions. And then we also put in place a system of closely monitoring the programs on the ground, rather more frequent than we used to do. For example, in our routine care, we usually used to get a monthly report from all facilities. But during this pandemic, we reduced that down to a weekly monitoring progress of all essential services. So we get a weekly report so we can easily track the changes across as we go along. So the weekly monitoring system has been put in place. So it's like a quick surveillance system. So we quickly check if the service is going on, and if there are any alterations to the usual expected trend, then we take action to rectify those changes. Next. Good. So the challenges, what are the challenges? We have done everything and the practice is good, but there are still challenges. Health facilities have remained overwhelmed with emergencies. This is very true. So a lot of patients are coming to, and a lot of facilities have been kind of like diverted to take care of the pandemic patients. So it is true that the health facilities are a bit overwhelmed with a number of other emergencies. There are a limited number of cancer care professionals, hence there is a need also to do some kind of mitigations to reduce exposure. For example, in Black Lion Hospital, in the biggest hospital, tertiary hospital, we have put a system of alternate day visit by care providers, by oncologists. This is to reduce the number of the exposure time with the patients and make sure that they are also healthy. And there is also a continuous monitoring of their status in terms of the COVID. And there was a general panic at the early stage even among healthcare providers. So healthcare providers were also subject to fear and panic during the early stage. I think that is slowly getting better. And at the early stage also, we have witnessed that patients avoided visiting health facilities. It's very true. This is because of the fear of contracting the virus while visiting the facilities. So unless it was an emergency, patients tended not to come to facilities. So unless they're really looking for it. So we have to do a lot of some sort of awareness creation and raising their
Oh, it looks like we have lost Kunuz.
So.
Yeah. Oh, sorry.
Hello.
Hello.
Yeah, I'm sorry. There was an internet connection failure.
No worries. No worries. Can you continue from there? Are you still seeing the slides?
Yeah, no, yeah, please. I think we're done with this one. Next one, challenges. We're on the challenge.
Yes, thanks. Next one.
Yeah.
Yeah.
Yeah,
so,
the next one is, I think I'm through with my presentation, so probably we can pick on issues if you have some questions to raise or some suggestions, points to make. Thank you very much for your attention.
All right, thank you so much, Kunuz. Sorry for the internet interruption, but it looks like we had finished all the slides. So it is really very informative presentation. It touches on realistic challenges we are really facing in Africa, that the pandemic is just straining the already fragile health system in Africa.
Yeah.
So, dear colleagues, I'd like to remind you that we shall have a protected time for discussion. If you have any question or comment to Kunuz's presentation, you can put it on the chat or note it somewhere. You'll get time to air this out. So at this time, allow me invite our second speaker, Dr. Warren Phipps. Allow me introduce briefly Dr. Warren as he pulls out his slides. Warren Phipps is an assistant professor at the University of Washington and an assistant member at the Fred Hutchinson Cancer Research Center in Seattle, Washington. Over the last 12 years, he has served as the medical director of the Uganda Cancer Institute Fred Hutchinson Collaboration Research Center in Kampala, Uganda. Oh, sorry, can you please mute your microphone if you are not speaking? Sorry. Yeah, sorry, I was introducing Dr. Warren, that he's the director, the medical director of the Uganda Cancer Institute Fred Hutchinson collaboration in Kampala, Uganda, where he oversees the program's research and training activities. He's also the director of faculty development for the collaboration and serves as the principal investigator on FOGAT NCI D43 training grant to support the development of early career investigators engaged in research on HIV-associated malignancies. Dr. Phipps conducts research on infection-related cancers in sub-Saharan Africa with a focus on HHV-8, the virus that causes Kaposi sarcoma, and also the pathogenesis of Kaposi sarcoma. He also studies the impact of HIV and antiretroviral therapy on cancer incidence and outcomes, as well as the causes of infections in cancer patients in Uganda. He's currently co-chair of the UCI COVID Task Force. UCI is the Uganda Cancer Institute COVID Task Force. So, Dr. Warren, we are excited and looking forward to hearing from you about the suggestions we really need to consider as we reopen the cancer services in Africa amidst this pandemic. So you are welcome, Dr. Warren.
Great, thank you so much, Annette. And thanks for that introduction. Next time, I'll definitely have to give you something much shorter. So,
no, it is necessary.
So what I had mentioned, I'm having a little trouble with my bandwidth right now, so I thought for the presentation, I'll keep my video off so I don't have a delay, but then I can turn it back on during some discussion period. So again, the group had asked if I could talk a little bit about factors for that should be considered for reopening and restarting cancer care services in the COVID pandemic. And that's certainly a huge endeavor. I think, you know, the reality is it's not going to be a one-size-fits-all, that a lot of local considerations are going to need to be in place, both at the country level and at the institution level. And really what I thought we could do for the next 10 minutes is to just have some ideas to spark the conversation, recognizing that in 10 minutes we won't be able to be as comprehensive as we'd like, and then I think really focus on the discussion, because I think that's where collectively we'll have the bulk of the ideas and experience. So in a lot of the themes that come out of this are very similar to what Knuz described with the experience in Ethiopia. And so, you know, I think just as a start, thinking about, you know, what is the risk of COVID-19 and cancer? And I think the emerging data suggests that cancer patients are a vulnerable population. So that includes both an increased incidence of SARS-CoV-2 infection among cancer patients compared to the general population. There are just a few small studies, well, actually not that small, a few studies that suggest higher cumulative incidence. Wuhan, for instance, measured about 1% of cumulative incidence in cancer patients compared to the 0.3% in the general population. In Madrid, it was much higher, with 4.2% cumulative incidence among cancer patients in the city. Certainly there's a lot of factors that are going to contribute to that, but it does appear that our cancer patients are at higher risk of getting the infection. But probably more importantly is that there's a higher likelihood of severe illness with SARS-CoV-2 infection leading to COVID-19 disease manifestations. And this apparently, as data is emerging, is highest in patients with hematologic malignancies. Lung cancer has been identified with a particularly high risk of morbidity and mortality, metastatic cancers, as well as cancer patients who are generally older and have other comorbidities. How much being currently treated for cancer or having an active cancer is mitigating the risk of COVID-19 severe disease manifestations is still unknown, and certainly that's under study, but the signal is not entirely clear yet, you know, outside of a few specific types of therapies. Another thing for us to consider when thinking about COVID-19 in our cancer patients is that for many respiratory viruses, cancer patients have prolonged viral shedding, and it's likely true with cancer patients as well. And so thinking about cancer patients who are infected with SARS-CoV-2 and if they're on your wards or if they're going to need to access cancer care, they may have a longer window in which they're shedding virus. So, you know, I think as Kanu's mentioned, and we've been talking about, the COVID pandemic has certainly had a huge impact on cancer care delivery around the world. These are just a few big areas, but certainly in cancer diagnosis, there have been a lot of delays, and that's come from both suspension of routine cancer screening services in most countries and regions, and also delays in healthcare seeking prior to diagnosis. And there could be a lot of reasons. It could be, as Kanu's mentioned, concerns about accessing healthcare, getting infected, limitations in transport. Uganda, for instance, had a very restrictive public transport policy for several weeks, which made it almost impossible for anyone to move within the country. Treatment has been impacted. I think surgery is certainly one of the areas that capacity has been reduced for many reasons. That could be including having to reallocate resources like ventilators, as well as concerns that providers and patients have with undergoing surgical treatments. And then certainly just reduced treatment services due to many of the factors that Kanu's mentioned in his discussion, you know, including travel challenges, capacity, and limited PPE. The other area that's important is that in many places, research has been suspended, including the suspension of new enrollment to clinical trials and some modifications to some trial regimens. And this is important not only for knowledge, but many of our patients do rely on the drugs or therapies that clinical trials provide to support their care. So I think the question, you know, really that is on all of our minds is, how do we limit all of these limitations on care and start getting closer to a new normal of care delivery as, you know, we go into the 6th month of this pandemic that really we don't see signs of abating anytime soon, although hopefully not at the same intensity. So a few thoughts on ways that we may more safely resume activities. And I think really a first is to establish clear guidelines for case management locally during COVID. And most of the international clinical cancer groups have come out with their own guidelines, and I'll include a list of those at the end of this presentation for a reference. But there's no final, you know, evidence-based international guidelines. We're obviously only 6 months into this. And so it's still important to consider your local factors, whether that's standard of care, what resources you have available to you, where you are in locally in the course of your pandemic in terms of whether you're in an ebb or a surge, will be really important in decision-making. And that similarly, I think across, especially institutions, being clear on what providers are going to use for criteria for making their treatment decisions will be very useful, and I think provide important support for providers and support when they're making these fraught decisions in this context. And really the goal of these guidelines is to balance the risks associated with delays in cancer care or treatment with the potential for significant morbidity that our cancer patients might have if they do contract SARS-CoV-2. And so I just wanted to share a couple examples. This is the European Society of Medical Oncology recommendations. They have this is just a way in which they're thinking about prioritizing cancer patient care, and they really have an emphasis on who needs immediate care versus who can be delayed. And so here, for instance, are some priorities, and it really is based on how clinically unstable or the magnitude of the benefits of the cancer treatment might have in the near term. Similarly, this is actually coming out of UpToDate. There's a very good review in UpToDate on some decision-making for cancer treatment that does compile a lot of the recommendations from the various societies. So I would recommend for folks who have access to UpToDate to utilize this resource. But here's another even more complicated schema where types of patient risks are assessed there on the left, and then an evaluation of age as a very important determinant of whether to proceed with treatment or not. And so hopefully you can see some of these, but just to give a sense, you know, a low priority that is considered safe to delay might be a non-melanoma skin cancer, a low to intermediate risk prostate cancer, or possibly even delaying radiation oncology for low-grade lymphoma. Some intermediate examples they gave were higher risk prostate cancer, as well as colon cancer with low risk for imminent obstruction. But some of the high priority areas. Oh. Are you still able to hear me?
We can hear you, Warren, very well.
Oh, okay. All right. I thought something was.
There is some echo, and again, I request our colleagues to mute your microphone if you are not speaking. Sorry, Warren.
Oh, no problem at all. And this is an echo group, so no problem. It's just getting in the spirit. So again, you know, our high risk hematologic malignancies is, you know, would be one that we would ideally not delay. So folks can look at these, and again, I think these need to be adapted locally, but going through this process with your clinical care team, this could be at the ministry level, this could be at your institution level, would be helpful to think through if that's not already been done, so that those prioritizations are clear across the institution. Some other strategies to minimize patient exposures to the healthcare setting and to avoid coming into the cancer clinic or hospital is, as those guidelines I just shared are really focused on, is deferring care as that's feasible. Although of course we're trying to find a new normal and resume care more safely. Another option is modifying treatment regimens. Are there options of transitioning somebody to oral chemotherapy regimens, for instance, and instead of having to come in for infusions, or could some regimens be shortened or accelerated? The NCCN, which many of you know well, has a very nice toolkit that provides some suggestions of formal chemotherapy substitutions, and that might be a very useful tool to use in your healthcare setting. Telemedicine is getting a lot of press these days for good reason, as an alternative to inpatient or in-person visits. I think this has been challenging in our setting to incorporate a lot of the video-based telemedicine, but certainly even phone calls that might allow a quick assessment as to whether a routine follow-up visit's needed or to help triage for emergencies is very useful. And that's something that the UCI has been piloting and trying to get more experience of calling all of our patients before their visits to help determine whether that visit is needed. Some other critical strategies that I think many places have already implemented include universal screening of patients, caregivers, staff, including, you know, a temperature and symptom screen prior to entering the facility, and a documentation that screening has been completed, preferably on a daily basis. Identifying a dedicated space to evaluate and manage suspected SARS-CoV-2 infection. This is hard. Often our centers are small and we don't have extra room, but if there's a way to have a physically separate area from your clinical carriers, that's useful, as well as a dedicated care team. So at the UCI, for instance, we repurposed these clinics that were being used for routine screening to become our SARS-CoV-2 triage unit. And also, of course, highlighting patient caregiver education, making sure our patients understand the signs and symptoms of infection and understand the mitigation strategies well. I think most countries are communicating these, but I think the more that our providers can continue to educate our patients about the importance, particularly given their increased vulnerabilities, is critical. A few other thoughts. Again, we're all working to maximize physical distancing. The ability of your institution to do that is going to allow us to provide safer care. So some strategies that folks have been using are setting up outdoor tents to use that as waiting areas, marking seats that are appropriately distanced so patients know where to sit, limiting the number of caregivers per patient. We're trying to limit ours to 1 caregiver per patient as much as possible. And I wrote decongesting the wards with a question mark. This has been a big challenge for us. We really need all of our beds, but coming up with strategies to decongest wards would be useful. Attendance is one way, but that might even be an area for discussion if others have come up with some good solutions. Ensuring that you increase hand washing facilities. This could be installing sinks, providing pocket sanitizers for your staff, and then of course enforcing universal masking. This might, each country still might have different policies on universal masking, but you know, it does seem that evidence is increasing that it's useful. And so if that's something you can ensure at your cancer facility, regardless of what your country guidelines might be, that is probably something that would minimize our risk of exposure. And then again, ensuring proper PPE and proper training of PPE. And then lastly, really investigating whether SARS-CoV testing can be established for your cancer population. And this could be working with your Ministry of Health to expedite testing in cancer patients given that they are a high-risk population, or if possible, even having capacity at your lab that you might set up in conjunction with your Ministry of Health. And if you are able to do that, you know, being very clear on an algorithm within with the ministry and within your institution of who would get tested and why. You know, this could be, instance, any symptomatic patient who's on the ward should be tested. If you have the capacity, it would be nice to test anyone who is initiating surgery or initiating new treatment. But again, a lot of that will depend on capacity. And then finally, I just wanted to mention staff. It's incredibly important that we remember to support and provide support to cancer providers and staff. Mental health is a big issue, as always, but certainly in this setting, I think our teams are at increased risk for anxiety and stress, and that can be not only because of the challenges of providing the care, but also concerns about their own health and the health of their families that they'll go home to, and realizing that many families are at home and they may have increased responsibilities at home as they still are going to work, but family members aren't, or children in particular. Again, ensuring that our staff have PPE, understand and have clear policies on not coming to work when they're sick, and that it's not being a hero to come in with a snuffy nose. And then last point, and I'd be curious if anybody has done this, is considering to establishing provider teams that are discrete from one another in case there is an exposure and need to quarantine a subset of your staff. If you have a way to either rotate staff, where some suggestions I've heard or have one team come on one week, another team replace them the following week, or have units that don't share staff members as much as possible, could be some strategies. But again, that might be something we can discuss. So with that was a few just thoughts to get our conversation going. I do have society links, as well as some information from NCCN, as well as those up-to-date links that I will import into this slide before we disseminate it, so that that's available to folks if useful. So with that, thank you for the opportunity to share some thoughts, and let's open it up for discussion.
Oh, thank you so much, Warren. That is really powerful, has been a very powerful presentation. It really gives realistic considerations and suggestions, and also references to relevant resources and guidelines. I like, for example, the realistic recommendation of limiting the number of caregivers in Africa. I just laughed, because for us in Africa, even a 3-year-old child can be part of the group that comes for caregiving. So it is really very realistic that those are some of the things we need to consider, while also considering the mental health because those are some of the services that are very neglected in Africa and given attention. But I really like that these are all the things that you have really brought out that needs to be considered, because really a lot of anxiety, not only among the patients, but also the health workers when it comes to risk assessment between COVID and cancer care. So colleagues, the floor is open for discussion, suggestions, comments. You can verbally put up your comment. We have a few comments on the chat. I don't know. We have, if I can try and project some so that let me see. Yeah, there is this one from Ben to Warren. He says that in the US, surgical services were also diverted for cancer treatment towards COVID-related services that by the time are more urgent. This was done with a prioritization scheme, since some cancer surgeries can safely be delayed while other surgical services are more urgent. Is it possible at UCI, Uganda Cancer Institute, to prioritize which cancer surgeries are delayed versus which are still performed? Or is it more of an all an option? And I think he liked your joke about the echo.
Well, I like his virtual humor too. So Ben, that's a great question. You know, I think it's actually probably critical to prioritize the cancer surgeries that are delayed versus which ones are still performed. I think the decreased surgical capacity is going to continue for some time, and that's at least in Uganda, I think for many reasons. You know, as you mentioned, you know, some of it's reprioritizing facilities to support COVID-related care. For instance, our National Referral Hospital, Malago, which has large surgical suites, has really actually been repurposed to take care primarily of COVID patients. So that's not as an attractive place to have surgeries as it once was. I think there's been a lot of concern among anesthesiologists about safety of performing surgeries on patients who, especially initially, were not being tested for SARS-CoV-2. I think that's getting better because at least that capacity is increasing. But we have a very limited number of anesthesiologists. So I think there'll be a lot of factors, but I think we have to prioritize. I think that's exactly right.
Yeah, thank you so much. I really had the same worry that now things, is it the services that should be stopped, or should it be case by case? Because when it comes, for example, a lump in the breast, surgery, it may be the best option and timely treatment. But I think so many things will continue to be considered. There was another comment on the chat. Sorry. Oh, hope I can go to read. Yeah, it was from Still Ben, and he was wondering about the radiotherapy services, saying that radiotherapy is the one therapy that does not have an application outside of cancer. Do the personnel who administer radiotherapy get pulled away to provide COVID-related services, creating a radiation slowdown? Or are the personnel and equipment still available to provide radiation treatment during the pandemic? Kunuz or Warren or anybody could have a go on this.
Let me take the first shot. I think for Ethiopia, the delay we have for radiotherapy services is not related to the COVID situation right now. It has been there before, and it's a continuation of what was existing before the pandemic. And also, we have not reassigned any of the radiotherapists to other services. They are absolutely dedicated to doing radiotherapy, so they don't have any other activity to do. The only thing that are affecting their assignment is the frequency of attending to their duties because of the exposure and like trying to reduce the crowd at the hospital, the crowd of the providers, I would say. So they might be put in an alternative date visit to the facilities. Otherwise, they are not reassigned to any other places. So in our case in Ethiopia, the waiting time for radiotherapy has nothing to do with the pandemic.
Yeah, thank you so much, Knut, for making that very clear. I request if you have questions, please, you can speak up. I would also request those who have a bandwidth that can enable you show us your face, please do that. Yeah, any more questions?
Could I ask just a follow up to
yes.
I think Uganda is very similar in terms of radiotherapy. I actually envision where radiotherapy services that is increased because it may even be more attractive than some of the other interventions like surgery. And I'm curious if anyone has actually an uptick in the demand for radiotherapy of the pandemic.
Yeah, thank you so much. Yeah, I still say anesthesia is very because during because it is going to deal with the mouth and respiratory system, and was wondering because in the US it requires a 72-hour testing for COVID before you go for surgery, but in settings like Africa there's no COVID test. Wondering what can be done. Thank you. Anybody who wants to make a suggestion on that?
Maybe I could just monopolize too much, but I think the testing is something we need to work together to increase capacity, across the country, but also advocate for our patient population and kind of fight for maybe prioritization of testing in some of these situations where surgery is going to be critical to especially if there's a curative potential. And highlighting that, but if there's a way to work with your ministries to help get the cancer patients prioritized appropriately, I think that might be one strategy. That's certainly something we're doing here in Uganda. Just as an example, not every group can do this, but we now have a lab at the UCI where we will be doing our own PCR testing. So we've been able to get donations from our collaboration through the Fred Hutch. And the ministry has agreed that we can use the PCR materials that we bring in specifically for our cancer center patients. So I recognize that might not be a solution for everyone, but at least it's a start for a small group.
Excellent. Maybe this one goes to either Warren or anybody. Warren, what about the plans? Because now it looks like we prioritize services. What about the plans for screening for cancer, screening services that are normally done at the Uganda Cancer Institute or other centers or other hospitals? What do you have to comment about that amidst the pandemic?
I'd definitely love to hear others' points of view. Just maybe a thought is we've currently suspended routine cancer screening. In many ways, we have our dedicated space to do our SARS-CoV-2 triage. But I think suspending services for 3 to 6 months might be reasonable. But at population level, if this continues, for a year or two, that's going to be a problem. So I think more thoughts on how we can offer routine screening is certainly needed. But others here, I think Ben, and others have a lot of experience with screening, maybe have more thoughts on how we can restart that in this pandemic.
Yeah, I really agree. Anybody, Douglas, do you have a comment? Oh yes, maybe start with Douglas and then Ben.
So thank you, Annette. So my comment is that is a great question. So I work within the context of the International Cancer Screening Network, and this is something that we're trying to figure out internationally. So, you know, and like what we're seeing all over the place is that most screening programs have stopped, be them regular, let's say opportunistic screening or established organized screening programs, population-based screening programs. Most of them have stopped. And that is the question. It's like, how do we restart them? There are several countries trying to figure out, and we're trying to tap into the international community to find the best ways, but this is an ongoing work. We had an initial survey of countries and got that information, and we're hoping to get some preliminary data out, you know, as soon as possible as we can. So that's what's going. But I don't have an answer to the actual question, like how do we restart? What's the best way to go forward? Sorry, Ben, go ahead.
Yeah, Ben, please, any comments?
Sure. So the point I would make about screening, and this of course would depend on the cancer we're talking about, but in the context of breast cancer, screening is not the most urgent issue. That we actually know that the delays of some months are not significant in ways that they would be for treatment of an established cancer or workup of a palpable mass, early diagnosis. So in fact, in the US, I mean, that's why the American Cancer Society looked at mammographic screening. This is not resource constrained, and said, actually, in women 50 and above, you should go every 2 years rather than every year, because it's hard to show a benefit of that. So you have, the analogy I would draw is screening is a little bit like holding your breath underwater. You can do it for a while. At some point, it becomes a problem, and what that duration is really the question. What I would argue is that the first thing to get going again, at least in breast disease, would be early diagnosis. You need to make sure that you're working up the palpable masses, because if they're cancers, they would be an established invasive cancer, and that would take priority over mammographic screening. I don't think we're talking about mammographic screening in the context of sub-Saharan Africa, but if you don't have diagnostic capacity, you're really stuck. It's not unlike the COVID issue. It's really hard to improve on COVID situations when you can't test to figure out who's COVID versus who's some other illness that sort of looks like COVID. I'm really sorry, but I'm gonna have to step off the call because I have a competing meeting. But thank you so much for this really great discussion.
Yeah, thank you so much, Ben. You've really had you've given us very great contributions and take-home points. So thank you so much for almost making it to the end. We have about a few minutes to close off this. And in the interest of time, I would like to close this discussion because we have only 3 minutes. And I would request members to continue the discussion on our base camp because this is important. And as you know, we can't plan for once. Even if we make a plan now, we can modify it next month or next year, depending on the available information and the new evidence about the pandemic and what can be done. It is really something we never planned before, but we have to plan to live with a pandemic. So thank you so much, Warren. Suggestions were many and great, and I would encourage the country specific to consider these in their national cancer control planning, amendments, and maybe addendum, and to make sure that we really continue to take cancer services as one of those essential services, given that the pandemic may take some time to go. So I would like to check on Christine, if you have any announcements, please.
Thank you so much, Annette. Just to remind us that our next session will be on August the 20th, Thursday, August the 20th. We'll be discussing about the impact of COVID-19 on cancer research. You're most welcome. If you have not received a link, please do let me know, or Mishka or Annette. Thank you so much.
Yeah, thank you so much, Christine. Yeah, I just want to re-echo that actually in 2 weeks' time, we shall have a session that normally follows in line with this one, because research affects the pandemic effect on research needed a detailed discussion, and we are having very great results about a survey that was done by ICRP about how research has been affected, and then we shall discuss how to move on with again cancer research during the pandemic. So I would like to thank Warren and Kunuz for their time and great presentations. And I would like to thank you all for attending today and actively participating. And I look forward to seeing you in the next 2 weeks. Take care and stay safe.
Thanks, everybody. Bye.
Thank you. Bye-bye.
Bye.